Welcome to the Reinventing the White Coat podcast, where we delve into conversations aimed at helping you foster a healthy relationship with your career and yourself. If you're a physician feeling unfulfilled or burned out or want to prevent yourself from going down that path, then this podcast is for you. I'm your host, Jennifer Shaer, pediatrician, chief wellness officer, and executive and life coach. Sit back and relax as we explore ways to live your best life and have a career in medicine. Today, I am pleased to introduce Dr. Herb Bravo, who is a pediatrician with a strong interest in practice management and actually a fellow podcast host of the Pediatric Lounge, which I'm going to want to hear about later. So thanks for joining me today, Herb.
Good morning. It's great to see you again. Thanks for having me on your show.
Yeah. Before I get started asking you questions, is there anything I missed in your intro?
No, that's pretty much it.
Yeah. I have one other thing about you that I should shout out. That is, you are a fabulous master networker.
Thank you.
Personally, I met you. We were introduced by a mutual friend, and then got to meet in person at the AAP, which was nice. And there's been this mutual sort of, oh, you should meet this person, you should meet that person. I love that. It's a great quality.
Well, thank you so much. There's so many geniuses in pediatrics, and they're all quiet, and they never seem to get together and share ideas.
Yeah. And
I would like for people to share more ideas, not in a 400-person room, but maybe 10 at a time. I think it's very important for your well-being, but also it cuts the time that you need to learn new things.
yeah, working collaboratively, sharing ideas, it's really, really great. So, Herb, when we first met, you shared with me a bit about your journey, your background as a doctor, and something really struck me about your story, which is that you had this way of intentionally and proactively sort of navigating your choices, which I think is something that many of us struggle with, and it can lead us as doctors and pleasers to some dark places. So I was wondering, with our time today, if you would be willing to share some of your journey to highlight that for our listeners.
Yes, I'd be happy to. So which one do you have in mind particularly?
Yeah. So one in particular struck me was sort of how you navigated that story about the NICU and just that whole period of time.
So I think that, I've had two not so happy experiences with NICUs. The first one was in Richmond, Virginia, and I was a hospitalist and an ER doctor at the hospital. Wonderful hospital, very well run. It's one of the flagship hospitals for HCA, and the CEO was extremely forward-looking. But as often happens to hospitals, volumes wane. And so the NICU volume waned. That's because they were doing less deliveries than they were doing before. And one of the four neonatologists wanted to move. And so they were going to move down from 4 to 3, which meant that they were going down from every fourth night call to every third night call. And they had the contract with one of these big corporations, Sheridan Healthcare out of Florida, that did the NICU and the PTR and the PEDS hospitalist. That hospital was a community hospital, but it had open heart surgery for kids, a PICU, an ER, a busy ward, and a high-risk delivery service. And so the neonatologist solution, since they ran the program, was to have the hospitalists / ER doctors, general pediatricians, cover the C-sections and the emergency calls to the labor and delivery at the same time that you covered the floor and you covered the emergency room. As you know, there's a couple of problems with that. One is that when you're in the emergency room on the floor at any given point, you might have RSV or you might have influenza or adenovirus, and you're walking into really what's supposed to be a very sterile environment and making one of these very vulnerable newborns sick with an infection that could spread quickly for the NICU. And we can do some things to mitigate that. But if you're calling me to run into a delivery, that mask is half on and the gown's half on, and the hands are not really washed because I'm running from one end of the hospital to the other. I also didn't know what to do if, for example, I was in a vaginal exam in a teenager and they call you to the labor and delivery room. Just what? I just run and leave her on the stirrups and come back whenever, or I'm in the middle of doing a spinal tap. What do I do?
Yeah.
And so I tried to talk to the neonatologist. They were, nope, this is the way we're going to do it.
How early in your career was this? What's the, like, how does this fit
I've been
into
three
sort of
years
your
of
life's?
residency. Yeah, 2 or 3 years of residency. And I said, well, you can do it that way. I'm just not going to stay here and watch this implode and then, be the one that gets sued or responsible for a bad outcome. But you guys can do what you want. I just don't have to go along with it. And since I'm not going to be able to persuade you to change your mind, I'll just look for another job. And I did.
Was
And
that hard for you?
no, for me, it's um. So what I tell people is, I am very OCD. I don't like doing things that are that I think are wrong. Especially when it comes to patient care. But I have a lot of in some ways I'm very easygoing, but I also will tell you what my non-negotiables are.
How did you
Uh,
know that?
I just know that I cannot be responsible for a labor delivery room that does high risk deliveries,
Mm-hmm.
C-sections. I think there are 2,500 deliveries a year, responsible for the ER and responsible for the ward at the same time. It's just not
Yeah.
possible.
Did
Um,
you always know you wanted to go into pediatrics?
no, I didn't want to be a doctor. I wanted to be a computer
Interesting.
engineer,
What
but I
did
have
you
a
want to be?
Catholic, a computer engineer.
All right. How'd that happen?
Oh, I have a mother that's Catholic, but she's worse than any Jewish mom you've ever met. So I said, I wanted to be a computer engineer. She said, isn't that just a club in your high school? I'm like, yeah, but it's a future. She said, I don't know about any future. You'd be a lawyer like your dad, a dentist, or a doctor. That way you can pay the bills for the family. So no more nonsense of computer engineer. That was it.
So wait, so Herb, at some point you weren't listening to your inner voice, you were listening to your mother at the
Oh
beginning.
yeah, yeah. My mother is a force of nature, so it wasn't worth the fight, especially because she's going to pay for college and medical school. So it's hard to argue with the money.
Yeah.
Um, so it turned out okay. I became a pediatrician because when I went to medical school in Costa Rica, I had so many wonderful mentors, many of them women. And this is back, 83 to 89.
Mm-hmm.
And I was in love with them. I mean, I just couldn't believe all the stuff these ladies and men of pediatrics knew. I mean, they were really so smart, and they had trained all over the world. So the pediatric infectious disease doctor that's my mentor in Costa Rica, Carla, she did her residency in Costa Rica and then went to Texas Children's and trained under George McCracken. And she was co-fellows with Mary Ann Jackson, who's now dean at Kansas City, Missouri,
Mm-hmm.
and a luminary in infectious disease on her own right. The immunologist, because if you called him an allergist, he would have a twit. Trained under Dr. Hansen, who discovered IgA immunodeficiency in Sweden,
Mm-hmm.
and he was doing bone marrow transplants back in '88 in children. And the professors from Sweden would fly for 2 weeks to Costa Rica because they weren't quite sure that they could trust their fellow who's already graduated to do it on his own. So they would come pre-transplant and they would stay for about a week after the transplant. Um, and then the nephrologist, I saw so many VCUGs. He trained in Houston at Baylor, That's where he did his fellowship. The dean of the medical school, um, the Children's Hospital in Costa Rica has his dad's name on the door because his dad founded it to treat polio.
Mm.
Then he did his residency at Hopkins and did his neonatology fellowship at Hopkins.
Yeah. So you had quite a number of mentors in
So
pediatrics.
you're in your 20s and you see these people that are writing papers and they pick up the phones and they talk to people that are writing textbooks of pediatrics like they're best buddies, which they were.
Mm-hmm.
And I was just like, man, this is the life.
Yeah.
The kids are fun. The medicine is hard. Um, it's so fulfilling and they're just so smart and they're geniuses. And you would never know it because they're all very unassuming.
Mm-hmm.
Um, so I fell in love with that. And that was just the reason why I wanted to be a
Yeah.
pediatrician. And I know no other thing I wanted to be.
And except for an engineer, computer engineer.
Yeah. Yeah. Well, I have to give that
That's
dream up.
okay. So then you went through residency and
Yes.
what did you went into what? General peds? What was your
Yeah. So I did 3 years in rural Appalachia.
you did
And
3 years of what? I'm sorry.
I was in rural Appalachia. So I was in
Ah, right.
I was hired by a critical access hospital in the middle of nowhere, Lebanon, Virginia, coal town, 40,000 persons in the whole county, 40-bed hospital, and they wanted to restart their delivery service. But to have a delivery service, you have to have a pediatrician on staff.
Mm.
And so they hired me, and I went there and I started the pediatric practice, and we got as far as getting the delivery suite open, but that was took 2.5 years because they weren't able to recruit the OBs.
Mm-hmm.
And so by the time they recruited the OBs, there's just no way that that practice could be sustainable. So that's when I went to the ER and the
So what are
hospital.
some before you tell me about the ER, what are some of the uh, um in rural Appalachia, what are some of the typical, different, I don't think many people have experience working in a setting like that. Were some of the typical issues that you saw?
Oh, I came from Chicago, which is, I think Russia had like 1,500 doctors.
Mm-hmm.
And it's, it's everything is very uptight. You go to the middle of nowhere, the hospital receptionist was the call service. And if a mom called, I mean, everybody knows everybody calls in because the kid's got a flu. She said, I'm not waking up Dr. Bravo for that. You wait till the morning, go to the office. And that was totally acceptable. I'm like, we might get into a lawsuit. And then, nobody's going to sue you. Nobody wants you to leave town. You really, really have to kill someone to get sued. Also, in that environment, you end up taking care of adult ADD because the family practitioners in town have no experience. They don't, and they're like, you took care of the kid, and the dad's got the same thing. Could you just at least do a consult for me? So mostly family practitioners, and it's a much more friendly environment
Yeah. Do
amongst
you
the
find it
doctors.
rewarding?
No, it's a lifestyle.
Yeah,
So I'm a city slicker.
I
And
see. Yeah.
if you want to live in Appalachia, you have to like farming
Mm-hmm.
animals. And the people that were really, really happy there, like there was a ear, nose, and throat surgeon. She was very good. She was married to a oral surgeon. They lived on top of a mountain on a 50-acre plot. They built a log cabin that was beautiful. It was one of the most beautiful houses I've seen with a pool. She raised horses and dogs. And when they weren't working, they were working on the farm. And that's what they want to do. They
Mm-hmm.
want to be on the farm. I don't even want to mow my lawn. So
Yeah. So how did you end up there, knowing that you're a city slicker?
I had a J1 requirement. So in order to get my green card, I had to give the government 3 years of service in underserved area.
Oh, all right. Where
So
are you from?
Colombia
Okay. And
is where I was born.
did you ever think about practicing medicine there?
No, my connection to Colombia is very dim because my dad's or was a diplomat, and then So I left Columbia to go to London when I was 3,
Hmm.
and I've actually never lived there.
Ah,
I've go back to visit, but
yeah.
never lived there. Didn't go to, not even preschool there.
Hmm.
So I have a much stronger connection, I think, to Costa Rica because I lived there twice. Uh,
So do you use your Spanish in practice frequently?
Not in Appalachia,
Yeah.
but
So you
it's the
committed
same
to
problem.
Appalachia because you had to do the J1, and as soon as it was
Yeah.
over, did you just run?
Yeah, as well, it wasn't a good setup. The nursery wasn't going. They're doing like one baby a month, and that's just not sustainable for practice. And the social interaction other than with your fellow physicians was really none. And I was still single,
Mhm.
um, and so it wasn't a good fit for me. I think it'd be a good fit if you like farms. You're already married. You got some kids.
Right.
Um, it's a different thing. Yeah, no, I
Yeah. So
didn't
what
run,
was your
but I
next, so your next sort of attempt on finding your path?
the next one, I am, I haven't figured it out. Um, you know, I'm getting near the end of my career as a pediatrician. I'm very concerned about the specialty of pediatrics in the U.S. It's underfunded, and
Hmm.
so we're not attracting young, brilliant people into the specialty.
Yeah.
People say, "Well, that's okay because we can replace you with mid levels." Only 30% of the mid levels want to go into primary care for the same reason. It's
Right.
hard work. Physically, it's hard work to see kids. Mentally, it's draining, and financially is not one of the best ways to go if you want to stay in medicine.
I love that you called it a specialty.
It is a specialty.
Yeah.
It is a specialty, and so I'm very concerned about that. And I think
Yeah.
that's one of the main drivers for the pediatric lounge is to make sure that people understand that it takes moms, it takes teachers, it takes nurses, and it takes pediatricians to raise the future. And it takes money because everybody's got bills to pay. That's one thing that I think pediatricians think money is a dirty word, but we all need money. Unless you're Bill Gates, you need money.
Yeah.
And so there is no reason to apologize for asking for money because, we all want to have a roof over our heads and 3 meals a day.
Yeah. So you are very active in practice administration and supporting pediatricians. How do you engage in that?
All right. So this is quirky, but I don't like sitting in a room. Like that whole NCE thing to me is like, I don't want to be there.
The
I
NCE
don't want to
being,
sit
just
in
for
a
the
room
listeners,
with
the
100
the
people that's dark, air conditioned, and somebody's got there used to be a carousel of slides. Now they have a PowerPoint on their laptop and they just go through the motions of giving you the information. I think adult learners don't learn that way. I think adult learners learn by sitting at a table with 10 people,
hmm
maybe one person that's really an expert on one subject, and then everybody else around the table asking questions of why this is good or why this is not so good for their practice.
right.
And I think that's the model that works. It's just very expensive. Um, but so I think what I like to do, what we'd like to do, and we're trying to do, is stand up a series of masterminds for different levels of people. Um, some people need the ongoing engagement, sort of what you do with coaching,
Hmm.
because they just need, they're in a solo practice. They don't have any partners. So whenever, and they're not allied. So they don't have a chief wellness officer. They don't have a
Hmm.
chief financial officer. They don't have a chief digital officer. They don't have a CEO. And they don't have a COO and a marketing department. And so whenever they encounter an opportunity or a challenge, they're sitting in an office in four walls, looking at the four walls, trying to figure out what they should do.
Yeah.
And so you get that kind of pediatrician into a group, and then the problems still come up. But now you might have 5, 7 people who can say, I think you're looking at it all wrong. Why don't you look at it? That's an opportunity to grow and make more money.
Mm-hmm.
These are the steps you could do. What are you comfortable with? And what can we help you do?
Yeah.
They also, and this is always, I don't know how you do this in your office, but pediatricians are so OCD. And there's no pediatrician that doesn't do growth curves. Never met one.
Right.
Some of them don't do it very well, but most of them do. But when you bring to the table data to pediatricians, they will argue like there's no tomorrow. If you say, I don't know, your net receivable ratio should be at 98% and you're at 80%, you're losing money.
Yeah.
The data is wrong.
Yes.
No,
Yes.
the
I
data
hear
is not
you.
wrong. You're not performing. Let's figure out why you're not performing and change it. It's not about who's right or wrong. It's about how can you improve.
Right.
But if they saw a kid that fell off the growth curve, the answer wouldn't be the data's wrong. The answer would be, well, how do I work up the kid?
Right. It's a symptom, right? You want to
It's
get
a
to the cause,
symptom.
the
It's not that
underlying
you're
cause.
good, you're bad. There's a symptom.
Right.
It's a warning sign.
Yeah. But most
Um,
people who go into medicine don't have an interest in, as you said, it's hard work and being primary care. Well, you're called a specialty, but going into pediatrics, it's not as financially rewarding. If we had an interest in finance, we probably would have gone into finance. So I think your expertise and your interest is so critical to support doctors who really want to keep their mission going because we need that expertise.
well, it's everybody's problem, right? I mean, I can be married to a very rich woman, but I still have to balance a checkbook because she's probably going to say you can spend this much money a month.
Mhm.
If you overspend over that, I'm going to take your credit cards away. And that's also true even if you work for a large health system. If you're losing a health system $150,000 every year, there's going to be a point where they're going to say, we can't carry you anymore. We're so sorry. We like you. You do great medicine. It's great that you take care of the kids, but we can't afford you anymore. So I don't think it's any more just people who want to run the practice. I think it's become everybody's business to know, that the bills are getting paid and you're producing enough so the bills are getting paid
Yeah, I sort of
before
liken
they
it
cut.
to, I liken it to, you have to do what to do, right? And when you're
Yes.
a kid, you don't necessarily want to brush your teeth, but you have
Yeah.
to brush your teeth. Like they're, so you might, it's very easy to do the things about your job that you love, and you could go with the flow and only do those things. But if you don't focus on the other parts of it, or at least outsource it to somebody who does and allow them to help you do it, then you're never going to be able to succeed holistically.
Yes. And then, so we've developed a dashboard to help practices figure out where they are and if they need areas of improvement or if something goes wrong
Mm-hmm.
before they have to get themselves in financial trouble. And that I think is very helpful. But as you know, in coaching and keeping people well, you can give people the information if they're not willing to act on it. It's absolutely of little value.
Right. Well, it's like giving
So,
advice on diet and exercise, right? You
right,
can only, right.
right.
But let me ask you, Herb, do you use this platform? Who do you work with? Private practice docs? What's the,
Yeah. So any private practice doctor that wants to, know more about how to run their practice, we can help them. And we do it either through the mastermind groups, the data analytic group, or one-on-one conversations.
yeah,
Some people just need an hour to bounce something off and they don't need to be
yeah.
there every week talking about it.
That adult learning model that you were just talking about in masterminds, it's so true. I know you were at the AAP, the NCE, that was the national conference, and you didn't go to any of the lectures, because you didn't want to engage in that. But I will tell you, in their defense, they are really shaking it up and making a lot more interactive sessions, similar to how, I don't know about your med school, but for me, I sat in a room for 2 years straight and just listened to lectures. And now they're doing much more case-based learning and much more interactive stuff because that's how you learn.
Yes. Well, it's not good or bad. It's the dollars, right? So to get, just 20 people at a time into a table, that demands more speakers, more space,
Yeah.
and people are just not willing to pay for it.
Do you do any of this virtually?
Everything is done over Zoom.
Over Zoom. Okay. So it's a team
Yeah.
based, so it doesn't matter where you are. So that's great.
Yes. No. Yes. So yeah. So it's not easy to do. It's not, it's not, I'm not criticizing the AP. It's just, you have to do it. You have to be efficient because people
Yeah.
are not going to pay
Mm-hmm.
$1 for 2 days. You me.
So, I think you froze.
That's everybody.
Talking,
So,
speaking about Zoom, I
but
think
yeah,
one of our
I think that,
connections,
if,
hold on for a sec. You're
let me see.
Herb. Can you hear me?
Yes,
Okay, we lost our connection for a second.
I
So,
can hear you.
okay, good. You froze for a minute, but we're back.
Okay. Are we back?
Yes. It was just right as
Okay.
you're talking about Zoom. We can do the best we can do, but the technology
Yeah.
sometimes
Yeah.
gets in our way. Okay.
Yeah.
So,
And so I think for the dashboard, yes, for the
go
dashboard,
ahead.
I think we've just started on the KPIs that are financially impactful, but we want to add some of the quality indicators, and then some of the physician wellness, because I see the podcast as um, an opportunity to learn from key thought leaders in the industry as to what's important. And the more and more I talk to them, the more they speak not only about being financially sound, that your quality is good, that you have good access, but also that you take care of your people
Yeah.
and how important culture is. Now, when I went to medical school and residency, taking care of your people and culture was of absolutely no concern.
Zero. Right.
Yeah, I was like, you know, if you can't do it, you're not fit to be a doctor. Get out of here.
Right.
There's a
And
line of
part
people.
and medicine attracts people who are there's back to your back to the beginning where you were able to stand up and say, no, this isn't reasonable.
Yes.
Um, the system takes advantage of us because most of us don't do that.
No. No. Um, Thinking independently is not taught in medicine. And there's a good reason for that because that's, the difference between a witch doctor and a physician is that we actually look for studies that say something's proven to work. We just don't decide today that, well, I'm going to try this, see if it works.
Hmm.
I don't know if it's going to work, but, who cares? We're not venture capitalists where, well, you know what? 2 kids died today, but you know what? 8 of them survived. That's a great win because that's how the venture capitalist thinks.
Right.
I invested in 10 companies, 9 died, 1 went to market, and I made a ton of money.
Yeah.
And wow, it's just a decision. You just can't think like that, you
Hmm.
know. But that's how they think. And, for us, we don't want to lose any patients.
Right. For sure.
So the whole paradigm is different.
Yeah.
I do think we need to start standing up more for ourselves.
Yeah.
And
And you're doing such great work on the practice piece. And you also still see patients part-time, correct?
yes, this from here until Thanksgiving, I'm in clinic every day because Dr. Sinha is going to go on holiday. So
Uh-huh.
yeah, I still enjoy that part.
Yeah.
Yeah, I
It's
still enjoy it.
nice. All right. So
How
Herb,
about you?
I want to thank you so much for joining me today. I want to ask you if you have any last sort of advice or words and tell everybody how they can find your podcast or if they're interested in your program.
Thank you. So if you want to learn more about us, is the pediatriclounge.com. The podcast is in every major player. So wherever you download your podcast, it's called the Pediatric Lounge. And the programs that we have are all through Pediatric Executive Development System or PEDS. And one thing I do think is very important for people to hear, and I think that no matter what you do in today's environment, everybody needs a coach. And I hear there's another lesson we've learned from key informants as we interview people around the country. The top performing C-suite executives in pediatrics, they all have a coach that they meet with to keep them on focus, keep them on track. And I don't know, it's no different. If you want to be a good tennis player, you're going to have a coach to help you. I think if you're going to be a good executive, you're going to have somebody coach you through some of the problems because the world's too complex today.
Well, that's a nice shout out for me. I couldn't agree more. Most of us don't realize how useful that is. We can't see what we're so in. It's able to sort of just get you thinking about what you're in the midst of. Just it really is really, really impactful.
Yes. I really, someone's listening. Doesn't matter who you hire someone.
Right. Yeah.
Because it's
I
really
agree.
incredibly helpful.
Yeah. All right. Herb, thank you so much for joining me. And I just want to take a moment for a great big thank you again to our listeners and for spending your precious time with us today. I hope to see you again for the next episode of Reinventing the White Coat. For this episode of Reinventing the White Coat. If you enjoyed this conversation, subscribe now so you don't miss an episode. If you're interested in coaching or in being a guest on the podcast, you can reach out to me online at shaercoaching.com. Thanks for listening, and don't be afraid to live your best life.